welcome to DIY Therapy. As always, we'll start with our disclaimer. This podcast is for educational purposes only. It is not designed to diagnose or treat. When beginning any exercise program, it should be reviewed and discussed with your medical professional prior to beginning. Information on this podcast is not designed to replace medical treatment. My name is Will. With me as always is Andy, and he has got some papers.
I've got some papers?
I heard papers floating around. I know that's not mine.
Oh, you know what? I'm doing some background work here because I've got a meeting I'm prepping for as we're doing this.
Oh,
we'll see how well I do multitasking.
During the meeting, you're just going to take papers. Like, I have papers.
That's all I have is papers. I have nothing to say, just papers.
Look at the papers that I have. Make it rain.
Yeah. So, what we're looking at subacromial decompression, right? Is that what we're looking at?
Yes. That sounds way more complicated than it probably actually is.
You want to give the audience a let's not call it a dumbed down version because that will alienate our audience. A watered down version.
Basically, you've been getting an impingement syndrome in your shoulder. So
what the heck is that?
Yeah. So that's basically kind of what it sounds like. Impinging means things are getting pinched together. Right? You're taking two hard surfaces and you're pinching something soft between it, and it hurts. It doesn't feel very good.
Ouchie.
Yes. So if you were to, how do I describe this? If you were to feel your collarbone and then follow that out to the side of your shoulder, you'll feel a bit of a hard bit right before it rolls off into your deltoid or your actual side of your shoulder. That's you're probably feeling your acromion. You can get pinching.
Which is a bone.
Yes. It's part of your scapula, your shoulder blade, right? Or is it?
Yes.
Yeah. Like for a second, I'm like, is it?
You say that with such confidence.
I know. I was like, I had to think about it.
Hold on a second.
It's sort of early. I don't know. Shut up.
Yes, no, it's attached to the scapula. It's actually the articulating surface or the surface where the clavicle will then attach to the...
the clavicle is your collarbone.
Your collarbone, which will then attach to your sternum. So it's a mechanism to get your limbs essentially attached to your the main part of your skeleton, which is really the whole spinal base.
Yeah, that's the weirdest part about the shoulder is the only attachment to your body is your collarbone right there.
Right there, absolutely, yeah. And then the scapula actually sits on the back side of the rib cage, and it's considered like a fake pseudo joint.
It's held in there by muscles and good graces and hopes and dreams.
Mm-hmm. Yeah. So that's kind of the joint in general. And so, like what Will was kind of describing is as you raise the arm up, a lot of times, especially when you get to about 90 degrees or above or about shoulder height, as you raise that arm above, there is some soft tissue that can be compressed underneath that acromion process, which is that bony process, up against the shoulder itself. And with repetitive strain, repetitive stress over and over again, eventually that could cause some irritation and or discomfort. So the common way that and the reason why we're having this conversation is because over the last several years there has been some probably some debate being raised through quality research that indicates that one of the main surgical interventions for this type of dysfunction really may have limited to no effect, like almost no significant changes. And that's why we're kind of talking about this today so that people can just be a little bit more educated in terms of what kind of decision-making process they have moving forward if they are having shoulder pain and the doctors, specifically the orthopedic surgeons, are recommending this subacromial decompression. So a subacromial decompression is where they actually will take that bone and they will shave off the underside of that bone. And what that does is it creates more space. Okay, it creates more space for the soft tissue to kind of operate, glide underneath that structure so that there is less irritation as the arm raises above the shoulder and or above the head. So the idea is by creating more space, obviously the less strain or repetitive stress is placed through that tissue, and thus that tissue then can go ahead and calm down. And so the and one of the reasons why it's also under kind of a hot topic right now is because of the fact that subacromial decompression surgeries are the most, and by a wide margin, the most common surgical intervention for the shoulder. It's believed that about 70% of all shoulder injuries kind of start or end with this compression or impingement type syndrome. And so if the end result is a surgery, but the surgery therefore is actually not very effective, then what is the point of the surgery? And that's kind of the education that we want to kind of provide today. Any comments on that, Will? Anything you want to add to that?
No, that's pretty self-explanatory. It's more of a knowledge base. What are the chances of this actually improving my outcomes? Obviously, it's a lot of people kind of immediately think that, oh, I'm getting a surgery, this will just fix it. I don't have to worry about anything else.
Yeah, and let me also kind of take a step back here. So the actual surgery itself, the subacromial decompression, there's low risk for infection because it is arthroscopic, and so it's not like it's a high risk surgery, and it's relatively benign in terms of what potentially could this cause future problems down the road, because anytime you kind of cut into the body, you have obviously other potential risks and reaction. There's always a cause and effect reaction when we go into the body. So it is relatively low risk unless you link it with a common problem that other surgeons will actually do with this, which is what is called a distal clavicle excision. Okay, so what does that mean? All right?
Yeah, what does that mean?
So a lot of times a subacromial decompression is also done at the same time as a distal clavicle excision. And what this is doing is it's actually cutting off the last third of the clavicle as you move out towards the shoulder. Okay, and the idea again is so that the acromion process in the shoulder blade can move more freely, because there is some type of degeneration in that where the clavicle and the acromion meet. There's some type of degeneration in that joint, and by removing that, it actually allows those things to move more freely and more independently. Now, the one problem with that aspect of it is anytime you're taking away any type of structural support, that inherently makes it more unstable. And so when you start talking about those aspects, now over a period of time, what happens 3, 4, 5, 6 years down the road after you have this type of surgery? Are you keeping your shoulder strong enough? Are you keeping it stable enough through strengthening exercises, et cetera, to keep your shoulder nice and strong? Or are you actually starting to become more unstable? And we've got to remember, the kind of basics of the shoulder in general, right? The shoulder has the most degrees of movement. In other words, it can move in a 360-degree motion. It is by far the most, has the most movement out of any joint in the entire body. And with that, though, already comes an unstable joint. Okay, so it means that
it's susceptible to.
Go ahead.
It's more susceptible due to the amount of mobility it has. It's more susceptible to instability.
Yeah, again, there's always a trade-off, right? So with that being said, when you take away one of these bony structures that helps to create stability, are you opening yourself up to more shear forces, more minor stresses that have this accumulative effect that can cause some more wear and tear down the line? And that type of question isn't answered yet. So let's be perfectly clear. I don't know that. I'm just posing that question. And the research doesn't tell us one way or the other at this point in time. It's probably a good question that people can kind of look into down the road. What are the effects of just a subacromial decompression versus the decompression with the clavicle removal? You just want to have conversations with your doctor to kind of ask them, what is the actual, what are you doing? Is it just this decompression, or is it actually the removal of the clavicle also? So that's something to just take note of. But what they found in the most recent studies is essentially that, and it's kind of interesting because this isn't usually the way that it works, but it's kind of interesting because there's now been enough evidence through research that has shifted the burden of proof for the surgery to actually come up with additional research to basically state its value, right? So there's now enough support in against the surgery to say, well, we actually are probably better off long-term not having the subacromial decompression and going through general exercise, strengthening, stretching, etc., versus doing the surgery. And again, this is the most popular surgery in terms of volumes that are being done for shoulder pain in the entire world. And so the burden of proof has now shifted towards, researchers who are in support of this to try to find research or develop research that says, yes, no, this is actually better than just conservative therapy, which, doesn't always happen, but is kind of a trend that's kind of going, even like with knee meniscal surgeries and arthroscopic surgeries in the knees. There's some research that's starting to come out in some of those different areas too. But it just shows that, some things that we thought earlier on, just 5, 10, 15 years ago, are all of a sudden now, as our research is getting better and more is being developed, that it's making things a little bit more difficult in terms of decision-making process. And a lot of what I will say about this too is that, if you are a shoulder orthopedic surgeon and this is your bread and butter, so to speak, surgery, there's a little bit of conflict of interest. So you just have to take that into consideration, that the surgeon, and I'm not bashing surgeons here. It's the same thing that with any kind of healthcare professional. You're given a certain amount of tools to try to treat your patients, and at the end of the day, you're going to assess them based upon those tools. And if they think that this can be beneficial for you, they're going to recommend it. But it's one of those things where you've got to recognize that they're looking just within their scope of practice and not necessarily outside of that sometimes. So ask the tough questions to your surgeon, have the hard conversations with them, talk to rehab specialists too. A lot of times you can give a phone call into rehab offices, and most therapists are really good about just being able to have a 5-minute, 10-minute conversation with them about things that are going on with them. So yeah, that's kind of where the research is pointing right now. Hopefully I said that clear enough. Anything that you need to clarify, Will, there, or that I jumped around or skipped around on?
No, it's pretty. It's we don't have. I think of the big takeaway that the too long didn't read is basically we're now having enough data from all of the surgeries. There's been enough time to tell us if these things are helpful or not. And it's kind of coming back as maybe not. Yeah,
and just to clarify, maybe I didn't make this point too. A lot of recent surgeries have done basically 2 separate groups or several different groups of, hey, I had surgery, these decompression surgeries, and then, hey, I just did conservative treatment, and guess what? The outcomes were literally the same within like a 3 to 6 month period. So again, do you want to go through the surgical process? Do you want to go through the cost of surgery? Are we trying to, as a whole community in general, try to reduce healthcare costs, or are we doing unnecessary surgeries that do open us up to the risk of infection or maybe instability down the line too?
Right.
So those are kind of the topics that people are having, and the 2 different groups kind of sit behind. So, I think the next step then, Will, is so if you are going to go through that conservative treatment, what are some of the treatment or practices to get people to have some decrease in pain or change some of those mechanics, et cetera?
Ice.
Oh, solid start. What's our go-to answer here, folks, at DIY?
Ice. Ice, probably scapular strength. Just more than likely this is happening because of poor position of the shoulder. Mm-hmm. And so you need to have, if you have this, more than likely you probably have a rounded shoulder and things are in a poor position. The easiest way to rectify that is improving your scapular strength. So the muscles like between your shoulder blades and your spine.
Mm-hmm. Yeah. So the whole premise of impingement syndrome is essentially that there is not enough space in the joint itself for those structures to glide through before they're compressed. So what a lot of people don't realize is that space based upon our positioning, that space based upon muscle length, muscle strength can be changed. And so what we would try to tackle in regards to treating this from a conservative standpoint would be how can we actually open up those spaces. Will touched upon it real briefly there. One is just simple scapular strengthening, strengthening up all the muscles that sit between the shoulder blade itself and then the spine back there. And specifically what we would consider the lower trap and mid trap, those are really the ones that are going to be more beneficial for you. Because a lot of times what ends up happening is the scapula becomes what we call protracted around the thoracic rib cage, meaning that it's actually being pulled out and around. A real good test for that is that you should have between 4 and 5 finger lengths in between your shoulder blade, the inside portion of your shoulder blade, and the spine itself. If it's anything more than a hand width and apart, or in terms of the size, then you know that you've got what we consider like a protracted or rounded scapula.
How many fingers length difference do you think the Mountain from Game of Thrones has?
Well, he is a giant of a man.
Or reverse that. How many of his fingers would be?
Well, it's all proportional, right? So maybe it's got to be his fingers to his scapula, right? You wouldn't do that to who's a tiny person? Tom Cruise.
Sure.
Tom Cruise out there. Yeah, so it's all proportional. Don't have somebody who is 7 feet tall test on a 5'2" person to see whether or not. Great point, Will, and way to throw in a
Game of Thrones. I'm getting antsy.
Right. Like to do.
Yep. Getting antsy. It's April.
Season premiere is around the corner here, folks.
Is it April? When
April,
is it?
Yeah. So then the other thing is the other major thing that happens is like the shoulder itself is what we would consider like internally rotated, which means that basically if you stand with your arms just kind of hanging by your side and you turn your thumbs kind of inward and towards your buttocks, okay, that would be an internal rotation. And so when we sit, when we lift objects, a lot of times that shoulder positioning is actually already in that internal rotation. So we would strengthen a lot of external rotators so that we could, the muscles on the outside that actually pull the arm out, we would strengthen a bunch of those to actually try to get ourselves into that more that kind of more open position. And then lastly, there's several structures in the front of the shoulder that actually will close that and pull those shoulders in, which again then closes that joint space. So we would try to stretch out the anterior portion of the shoulder. So that would be how, like, conservatively we would go about it. And again, when done correctly, conservative treatment really, and not in all cases. Let's make that perfectly clear too. There is certainly appropriateness for subacromial decompression, but in many cases it can be treated conservatively. I think one of the big takeaways from all these research pieces is that. Well, one is that a lot of these subacromial decompressions were actually being performed not because there was true impingement, but because there was just arthritic changes, and therefore the results weren't very good. Okay, so that's number one. So I think, and then number two, the other takeaway from it is that they need to define the criteria for what patients are actually more appropriate for these surgeries, so that they're not just lumping everybody into one big bucket and doing these surgeries just at mass volumes, right?
Yeah, when you're a hammer, everything's a nail kind of thing.
Yeah, so and most likely that's the next step, because a lot of the current research that's actually coming out right now, I mentioned earlier that, the burden of proof is now to prove that these surgeries are more effective. Well, they're going to be more effective when you get a better patient, a better group of patients that actually, need the surgery, in a more appropriate group of patients versus just a larger volume that maybe some did and some didn't. So
Yeah.
I think that's the next step, is probably defining who is actually more appropriate and getting those guidelines a little bit more. So that's a great question if you're in line for one of these surgeries to actually have with your surgeon. So I don't know. I've rambled probably way too long about this. Standard.
Well, if you have any questions, you can always email us at DIYtherapy206@gmail.com. You can follow us on Twitter at DIY Therapy or Facebook group, and we also have the Instagram. As Graham, you hate it when I say that, but I think do the kids say that? I don't entirely know.
I don't know. My kids don't, but
our kids are too young.
My kids
to
are 4 and 7, so hit me up on the gram. What my high school patients say. Or what's the other one? Snapchat.
Snapchat. It'd be hard to have a Snapchat. Yeah.
Yeah. I don't know. Anyways, that kind of dates Will and I. Yeah. Anything else?
Nope.
All right. Disclaimer time.
This podcast was for educational purposes only. It is not designed. Is not designed. No, I'm gonna edit this out.
You do not edit this out.
I am not gonna edit this out.
This is raw, baby.
It is not designed to diagnose or treat. When beginning an exercise program, it should be reviewed and discussed with your medical professional prior to beginning. Information on this podcast is not designed to replace medical treatment. Remember, treat yourself.